All right, Rick, welcome to the podcast.
Oh, I'm very excited to be here. Thank you.
Yeah. So why don't you just start off? I feel like people probably won't know who you are. So why don't you introduce yourself a little bit and what you do?
What? People won't know who I am.
Oh man, now they will. Everyone in the world will,
That's
Rick.
right. That's right. My name's Rick Olderman. I'm a physical therapist. I've been a physical therapist for over 25 years, a sports and orthopedic physical therapist. And by necessity, I ended up focusing mostly on chronic, nagging, or recurring pain conditions. And that's kind of where my expertise ended up going.
Okay, cool. Then when you got into physical therapy, I just feel like the trajectory for physical therapists is that they kind of start off as trainers. They figure that they want to do something a little bit more with it. So what was your background with that? Have you always been into fitness? Have you gotten injured a lot? What kind of led you to choose physical therapy as your career?
Well, I had never even heard of physical therapy until I was like 27 or 28. I grew up on a farm, and
Okay.
that term, you get hurt. That's just the way it is, you know.
Yeah,
So,
that's true.
so I developed back pain. I also had kind of chronic neck pain from extensive nerve damage playing football and wrestling in high school. And one of the reasons I went into PT school was to try and solve my own pain.
Okay.
And the premise that I had going in was there must be something I'm doing that's causing this pain.
Mm-hmm.
And so I thought, I can't wait to learn what it is.
Yeah.
Except that never happened.
Yeah.
Through all of the schooling, all the treatments and so forth that they showed us, nothing ever helped my back pain or my neck pain. And then I got my first job as a PT in an orthopedic clinic in a rural community. I was one of maybe, I think, two PTs out there. And instantly, I knew that I was a failure at a PT helping anyone with chronic pain because I could not help these people. It was a different set of rules with chronic pain or recurring injuries or nagging issues versus an acute issue like a sprain, strain, post surgery, things like that. And I was sunk into a deep depression because of it. It
Wow.
wasn't until I moved to Denver and I went to work at this exclusive health club downtown where I was the only PT on staff. And my schedule was instantly filled with people with chronic and nagging injuries.
Yeah.
I'm just
Yeah.
like, what? I mean, this is like the cream of the crop, doctors,
Yeah.
PTs, chiropractors, massages, you name it. And I'm just like, you're still having, and these were all like younger people, great health
Mm-hmm.
insurance, professionals, intelligent, and they all had chronic pain. And that's when I realized, oh my gosh, we in medicine in general are not doing well with chronic pain. It's not just me. And
Yeah.
that's when
Yeah.
I just figured I got to figure this out or quit being a PT because I couldn't handle being a terrible PT.
Yeah.
Yeah.
So, well, go ahead. Go ahead,
Well, I was
Tyler.
just going to say, aligning with that, like we have worked with, so we work with some physical therapists and medical professionals and things on like post rehab or even in conjunction with PT sometimes with our clients. And we're very much of that mindset of you have to get to the cause of the issue versus just fixing the thing, right? And so, yeah, elaborate a little more on why does this concept not align with the medical training you received?
Yeah. So some people call one thing a cause and other people call
Yeah.
another thing a cause.
Yeah, that's the problem.
So
Yeah.
every medical professional or every trainer or every Pilates instructor, whoever, always believes that they're solving the cause of a problem.
Mm-hmm.
The problem is their point of view that they're coming from.
Mm-hmm.
And so, in physical therapy school, we were taught what I call component thinking, which is that we are taught we learn all the muscles, all the nerves, all the blood vessels. We know where everything is. We know exactly what it does. And our goal is when we identify a tissue, and by the way, we have 1,000 different tests to identify exactly which tissue is damaged, X-rays, MRIs too.
Yeah.
So the idea is that, oh, once we identify what that tissue is, we can then treat it and it'll heal. And that works again great for acute issues.
Mm-hmm.
But and I call it component thinking because what we're doing is constantly breaking the body down into smaller components to understand exactly what the damage is. What tissue is damaged? And we think that if we know what that tissue that is, then we'll be able to heal it. But chronic pain is showing us exactly that does not apply, right?
Right.
Because that tissue has healed. It's just hurting,
Yeah.
right? And so what I've developed over time is something I call a systems approach. And that means we have to have a broader understanding, not only what tissue is damaged, but why that tissue is damaged. We do not have any tests orthopedically, MRIs, X-rays, or whatever, that tell why a tissue is damaged. And that's what I've been figuring out for the last 25 years.
Yeah. So do you feel like that most physical therapists are more in the mindset of treating, as you described, the more acute tissue damage, and that's why people go there, and then they might just have to go for a while because maybe it is chronic and that's their, that's their method? Because I know you were saying that you kind of developed a different method because you're trying to really get to the root of the issue, which I think most physical therapists are trying to do in a sense. But I know the experience that I had a back injury and I went to physical therapy, but it was still flaring up. It was still hurting. And a lot of the movements that they did, they wanted to help fix the current pain that I was in, but it wasn't like, let's continue to figure this out. It was like, we fixed the pain, you're feeling better. All right, cool. You're done with your session. So I guess my question is, what is your approach to that and finding the chronic pain and where that's coming from, and how does it different from, I guess, what you're seeing in the field itself?
Sure.
Yeah.
So over time, what I've done is I've developed a way of looking at the body, like I said, from the systems approach. So I've broken the body into two different systems.
Okay.
One, if you come in with back, hip, knee, foot issues, that's one exam. That's the lower body system that we're going to be evaluating. And if you come in with any kind of shoulder, neck, headache, anything like that, that's an upper body system. So the lower body system starts with the rib cage and everything down to the foot. And we evaluate everything. It sounds like it would be a whole heck of a lot of things to evaluate. But over time, what I've done is I've narrowed down. There are key tests that you can do that give you a lot of information about why a problem is happening. So really, it comes down to maybe 10 different tests. And in fact, the Zoom sessions I do, often I'm only doing 3 to 5 tests, and I understand everything that's going on in that lower body system.
Okay. Wow.
In the upper body system, we start at the pelvis, and everything above that feeds the upper body system.
Yeah.
Now, of course, the two systems are linked. We can talk about that, but often I don't need to link those systems in order to solve chronic issues. So basically, that's what's going on is when you come in for a back lower body issue, we're looking at the lower body system and vice versa. So we look at different things. I'm not even looking at the tissues that are damaged.
Yeah.
Right. Because they're damaged.
Right.
So
they're going to be painful.
why do I want to press on that?
Right. Yeah.
So what I want to do is understand really what goes on with the body is that chronic pain is occurring because of forces that are acting through an area rather than a problem itself with the area.
Right.
Does that make sense?
Yeah,
and those forces can cause structural problems like disc bulges, herniations, and things like that, right? But ultimately, it's the forces that are acting on that area that are actually causing the pain and likely those structural issues too. In medicine, what we've done is we focus on the structural problems like the bulges, herniations, and so forth.
Yep,
let's treat these problems, right? But we're not addressing the forces that are contributing to those problems. And I can take you through an example if you want to see what I'm talking about. It's for back pain.
Yeah, definitely. I feel like the clients that I've trained who've had specifically back injuries, in which we're going to talk about Heather in a little bit, but they always tell me that they went to get an MRI. I actually just had a client call me today. She hurt her back, and it wasn't even from our workouts. It was from something else. And she was like, I just know this is structural. They've been telling me it's structural. I'm going to go get an MRI. She got an MRI, found out there was nothing structural there. So I just feel like most people, well, I guess you can give me your thoughts on this because you're the actual physical therapist, but we'll just stick with the back pain, for example, because I feel like that's the most common. I feel like most people are probably walking around with some sort of bulging disc or herniation, et cetera, et cetera. So I guess, how do you deal with like people getting hung up on the structural issues, but also educating them in a way that's going to find the root cause and potentially help fix their chronic pain, because you can't really do anything about structural issue. You have to figure out how we're going to get rid of the pain. So how do you deal with that? And I guess the client's mindset regarding that, because I hear it all the time. Yeah.
I can answer that question through the demonstration.
Perfect. Yeah.
Let's
Love
do
that.
it.
Let's do that.
Okay. So everyone at home, and by the way, I think parts of this, or maybe the whole thing, is going to be on YouTube. So if you want to, you can see the video of this, but I'll try and describe it so that you don't need to see the video.
Yeah.
Okay.
Both are great. We have a little skeleton for everyone who's not watching. You should definitely watch, because there's a little skeleton.
There'll be a link in the show notes if you'd like to click on that and watch.
Okay. So basically what I'm going to ask everyone at home to do, especially if you have back or sciatic pain, is to lie down on the floor with your legs straight. Pretty simple. All right. If you can't get on the floor, then get on your bed, get on your couch, just lie down on your back with your legs straight.
Cool.
And I want you to feel how your back feels in this position. All right. And so we're going to stay there for about 30 seconds. And then what I want you to do is you're just going to simply put your feet on the floor instead and bend your knees. All right. And if you don't feel a difference in your back between those two positions, go ahead and hug your knees up to your chest if you want to.
Okay.
Okay. Now, one of those two positions is going to feel better for your back.
Mm-hmm.
Which position is it?
Heather, which position is it
the
for
knees
you?
bent, for sure.
Exactly.
All the way to your chest?
Well,
99
no, just knees bent. It's good.
Yeah, just knees bent.
Anything other than straight is good.
Yeah,
right,
exactly.
Heather? Okay, so what that's telling us simply is that, and what's happening when my legs are straight is that my back is more arched, and when my legs are bent, my back is less arched. So really simple, okay?
Yeah.
So now we know that if your back is less arched, it feels better. Now, if you have a disc herniation, disc bulge, spondylolisthesis, stenosis, or anything like that, if you have a structural problem like what you were talking about, Katie, that shouldn't matter whether your knees are bent or straight.
Exactly. Yeah.
Because we haven't changed the structure.
Right.
We have changed the forces acting on the structure.
Perfect. Yep.
And so this is what I'm talking about. This is how we get people to understand in the clinic. Oh, you've got a disc herniation? Okay, well, let's see. Do this very test with them. And oh yeah, I have to sleep with my knees bent all the time because that's the only way I can sleep. Okay, so this doesn't change the fact that you have a disc herniation. What we're changing are the forces that are acting on that disc herniation. Where are those forces coming from? Well, clearly they're coming from the legs, because that's the only change that you've made in the body is to bend the knees versus not bend the knees. So it's really the muscles coming and the mechanics coming from the legs that are then acting on the pelvis and therefore the spine. Because look at the pelvis, it's this big bony flat bone thing. And you've got all these joints in the spine. So this big bony thing, you're not going to feel pain in the pelvic bones because there's nothing moving there, right? The spine is responding to the pelvis. But what's making the pelvis off? It's the legs. So the legs are ultimately working on the spine via the pelvis. And if you change those forces, you'll fix back pain. Just like you saw on the floor. If your back felt better at all with your knees bent, all you have to do is change the forces acting on your back. You don't have to change the disc herniation.
Yeah.
Right.
Perfect. Well, I love that.
I can give you an example of one of the things that is causing that force to happen.
Yeah, please do.
Okay. So one of the things that I've been looking into all these years is, okay, I get it. Forces are the thing that are causing the problem. But what are we doing during the day that's causing these forces to occur?
Yeah.
Right? That was the big question. And so one of the things that we're doing, if you all want to do this test, this is also really important for you to understand. Now stand up. All right. And so we're going to stand up here for the next maybe 2 minutes and listen to Heather and Katie and myself. And what you'll notice is after a minute or two, you're going to notice that your knees are starting to lock backwards in a straight position. Okay. And if they're not locked straight already, go ahead and lock them now. All right. And you'll feel what your back feels like in this position. And now what I'd like you to do is to simply unlock the knees. You don't need to squat. You just need to simply unlock the knees. And if you're not sure what that did to your back, go ahead and lock the knees one more time. And you'll feel that when you lock your knees, your back is more arched. You'll actually feel more contraction of your back muscles when your knees are locked versus when your knees are not locked. Okay. So what is this test telling us? Well, this is telling us that an unconscious habit that you have, that of locking the knees if you're standing for more than a minute or two, is actually causing your back to undergo more extension or more arching. which is what we found hurts your back on that first test. So this is what you're doing. One of the things that you're doing during the day that's contributing to your back pain. If you simply stop locking your knees, this is how beautiful it is.
Yeah.
If you simply stop locking your knees, in 2 or 3 days, your back pain, usually it reduces by between 40 and 70%.
Wow.
Just by unlocking the knees. Because if you think about it, if you're taking 10,000 steps a day,
Yeah.
and all 10,000 of those steps involve you locking your knee,
Mm-hmm.
that's 10,000 hammers to your back.
Okay.
Unlocking the knees removes 10,000 hammers.
Okay. So are you recommending that people, if they are suffering from the sciatica, this back pain in this example, are you recommending that they don't walk and then just kind of stand with their knees bent more often? And or are you doing other strengthening movements as well? Or are we just first assessing and what they're doing throughout their day that's potentially contributing to it? Or I guess, is that all part of it too?
It's all part of it, because through my exam, I'm seeing, so the habits that are causing your pain are also creating tired or weak muscles.
Okay.
For instance, if you lock your knees, you're turning off your gluteal muscles.
Yep.
The gluteal muscles are one of the primary pelvic controllers.
Yeah.
They also control the tracking of the hip joint in the hip socket. So there are consequences of locking the knees other than just causing the back to arch.
Yeah.
There are other muscles that then become tight or contracted or weak because of that. So we're also correcting those things as well.
Okay.
And just so you know, this is one of the primary causes of more central back pain.
Okay.
If you have unilateral back pain on one side, or you have sciatic pain or SI joint pain, it's also due to another habit or another pattern called a side bending problem, where one side of the pelvis is higher and the same side rib cage is lower, which, as you can imagine, creates compression on this side of the spine. All right. Well, the areas of the spine that creates compression on are what comprise the nerve roots of the sciatic nerve.
Yeah.
Right. And so this pattern is typically due to an older problem, usually in the same leg, in 80 to 90% of the cases. And in 10 to 20% of the cases, it's due to a compensation pattern from the other leg.
Got it.
This is very easy to fix and is often misdiagnosed as a leg length discrepancy.
Yep.
Because a practitioner will see, oh, you've got one hip that's higher than the other. You've got a leg length discrepancy. Absolutely not. You do not have a leg length discrepancy. I've tested hundreds of patients over the years who've been told that they have leg length discrepancies, and maybe 3 have had true leg length discrepancies.
Yeah, that's
so
really
this
funny.
is a compensation pattern.
Yeah, it's funny that you say that, because I have a current client who is so adamant that one leg is longer than the other. And I'm like, I really don't think that's the case. But she's just so adamant. And luckily she doesn't have any like terrible back pain or anything from it, but could potentially, cause some issues here and there. But she's just so adamant about it. And she has been for years and years and years. But it's just funny that you say that. But anyways, continue.
Katie, this is so common because she didn't come up with that herself.
Someone told her. Her doctor told her.
Yeah, exactly. So this is, and I talk about this in my new book, the Solving the Pain Puzzle book.
Okay.
I have a case where a woman brought in a full body x-ray of her daughter, proving that she had a leg length discrepancy.
Yeah.
And I looked at the x-ray and I said, no, that's not a leg length discrepancy.
Yeah.
And we fixed it in 5 minutes.
Yeah.
Yeah.
And she going, but how did you do that? Because it's not a leg length discrepancy. It's a compensation pattern.
Yeah. Right.
Can you explain how you fixed it with this client? Just curious as to your protocol about that.
Do one of you have one pelvis that's higher than the other? We can fix it right now.
I think it's well, I have a right knee issue that has led to my right back issue.
Yeah.
Similar to what you're talking about. So potentially.
Yeah.
Katie, can I ask you to measure Heather's pelvis? I'll show you how.
Yeah.
And then we can confirm.
Okay.
Because
tell me how.
This is powerful.
Okay.
So
cool.
Heather, I want you to turn your back to Katie. Katie, you're going to get down on your knees behind her.
Okay.
And you're going to put your hands right on top of her pelvic bones. Look at my hands.
Like this.
My hands are like this. This is how I want your hands to be.
Okay.
All right. Now you're on the back of her pelvis. I want you to be on the sides of her pelvis.
Okay.
So move out to the side. There you go. Now you can really feel the tops of the pelvic bones. You feel those?
Yeah. Hitting them, Heather.
Okay, now Katie, which hand is higher?
I feel like the right one, this one is slightly higher.
It should be higher because she has a right knee issue.
Yeah.
Okay. You feel pretty clear on that, Katie?
It's very minimal, but yes.
Okay, so what might help you is if you push into her soft waist muscles, go above where your fingers are, push into her soft waist muscles, and you'll feel more definitively the heights of the pelvis.
Oh, yeah. Now it's definitely clear. The right side is higher.
Now it's definitely clear. Yes,
Yeah,
exactly.
yeah.
Okay, I can see it from here.
Yeah.
Okay, now you're going to stay down on your knees, Katie. All
Okay,
right.
got it.
Heather, I want you to raise your right arm up in the air. I want you to take 10 steps around that room. You can go out the door if you want. Take 10 steps, and Katie's going to come back and measure you.
This is fun in our little office.
Yeah. Okay, measure her again, Katie.
Okay. Honestly, probably about the same right now.
Okay, go take another 10 steps. And this time, Heather, when you take the 10 steps, I want you to linger on the right leg, and I want you to reach your right hand up in the air more, because your hand was like here. So really reach up there. There you go. 10 steps. That's more like it. Okay, measure it again, Katie.
Okay. I feel like it's slightly higher again. Maybe I just suck at measuring.
Okay, so that, if I was there, it would have been fixed.
Yeah.
But this is how we do it. So this, in all cases, it's been 100% until we just did it with Heather just now.
I think that's a what the
But in
measure
100% of the
error, yeah.
cases,
user error.
what this simple little technique levels the pelvis and the rib cage. So what does that tell us? It tells us that the side bending problem is due to a walking pattern,
Okay.
right?
Yeah.
It's not due to a leg length discrepancy.
Okay.
So for me, a little background. I was a competitive power lifter, and the bilateral squat, I think, is what messed up, because I have knee pain, and so I compensate for it.
Yeah.
And so there was a lot of load. I mean, there was 300 pounds, my squat was, right? And I'm like a 120-pound girl. So over time, I think maybe that's why the walking is not quite doing it, because
Probably.
it's intense and it's flaring up this last week.
Yeah,
so yeah, but that's some background.
I bet you, Heather, that we could get that to go away within 3 minutes.
Okay, let's do that then. What do you recommend for her?
Well, first of all, that gait pattern. So what I want to confirm your measuring technique, Katie. First of all,
it's not confirmed.
It's very unusual, especially knowing that Heather has a right knee issue.
Yeah.
It's very unusual that would not have fixed the pelvis and rib cage.
Yeah.
I think it's user error.
So that's,
but yeah.
That's the first thing I would do, is confirm that the measuring is done correctly. But that walking technique does it. So the other things, so it's really interesting how you described your injury, Heather, as a squatting issue, right? But the squats maybe not have been to blame, but maybe how you were doing the squats.
Right.
And what I mean by this is, this brings in the idea of femoral retroversion and femoral anteversion.
Yes, this is what I wanted you to talk about.
Yes.
Yeah.
Yes. Elaborate.
Yes. So this is a very common thing. In fact, I just in my book and on my podcast, I worked with an NFL player with 9 years of hip, knee, and ankle pain, who he was playing, and he needed some help getting rid of this. And we got rid of it in 3 days. This was 9 years of pain while he's playing football, just by having knowledge of femoral retroversion and anteversion and applying that to how he was exercising.
Okay.
Wow.
So interestingly, his pain didn't begin until he started playing for a Division I school, and all of their athletic trainers told them this is how you're going to be squatting.
Yeah.
That's when his pain began.
Yep.
Because they didn't understand the idea of integrating the understanding of femoral retroversion and anteversion into their squat technique and modifying it via how the player was built versus what they believed the technique should be.
Right.
So here's what I'm talking about. So, if you look at an anatomy book, it makes it look like all thigh bones are shaped the same.
Right.
But they are not.
Yeah.
Right. Some thigh bones are twisted outward, and that's called femoral retroversion.
Okay.
Or an externally rotated thigh bone.
Okay.
And some thigh bones are rotated inward or anteverted. And this is called an internally rotated thigh bone. Okay. So there are ramifications for how you should use your legs based on the shape of your thigh bone. So what a lot of squatters are taught that I've seen in my personal training career is that they are taught to point their feet forward and squat.
Yeah.
All right. So, but if you have a retroverted thigh bone, one where the thigh bone is rotated to the outside, and you are pointing your feet forward, you are then forcing the thigh bone to be in excessive internal rotation.
Yeah.
Right? Because it has to align with with where the foot is pointing. Well, internal rotation causes increased compression at the hip, knee, and foot. These joints don't like internal rotation. And so if you're squatting and undergoing internal rotation, now you're adding compression onto the load that doesn't need to be there. All right.
Okay.
So this NFL player had one retroverted femur and one anteverted femur.
Wow.
So what we ended up doing was and what he was taught to do his pass sets was to back up and point his toes straight into the ground on that retroverted femur to create a post against which no defender could come through, right?
Okay. Yeah.
But if his foot is pointed straight into the ground, he's now in internal rotation relative to the shape of his thigh bone. And simply by having his foot point straight down, he is now in maximal internal rotation of that thigh bone, increasing compression and it makes him weaker, increasing compression at the hip, knee, and foot joints. Okay. This is why he developed chronic pain. And all of his squatting was with a foot pointed forward. That's absolutely incorrect for the shape of his thigh bone, and which is why he had 9 years of pain.
Yeah.
But the nice thing is, it was resolved in 3 days just by simply getting him to turn his foot out to match the shape of his thigh bone. Pain melted away. And this is the beautiful thing about the body.
Yeah. Was that only on the one side? Since you said one was
okay, this is the interesting thing to me. So back when I first started powerlifting, so I've always believed in, a little bit of turnout on the toes so the knees track. And one foot, my friends would always say that one foot was turned out a little more. And I tried to fix that.
Yeah, maybe she shouldn't have.
Maybe that's the problem.
Correct.
Yeah.
Exactly.
Because, maybe I should have kept that foot turned out a little more.
Yeah.
Yeah, this is the interesting thing is when this guy was in high school, lifting, squatting all this weight, right? No injuries at all. Because he squatted, no one told him how to squat.
Yeah.
It was only when someone told him how to squat that he started to get his injuries.
Right.
Yeah.
Right?
Yeah.
And this is why this is when I first started working as a PT, a personal trainer. One of the trainers ran up to me while I was doing a lunge with someone and started yelling at me because I allowed their knee to travel over their toe when they were doing a lunge. I'm just like, well, I don't understand. What you're not supposed to be able to do that. I said, well, then why is the ankle built to allow this to happen?
Yeah. Exactly.
How do you walk up the stairs?
Yeah, exactly.
So anyway, so these kinds of myths, it's not only personal training, it's floating, they're thrown like leg length discrepancies.
Yeah.
These myths are floating around in medicine that are it's the way things have always been done. And no one's really taken a hard look at, hey, what's the validity of this idea?
Yes.
And that's what I've been looking into for the past 25 years and coming up with this whole systems approach to understanding things.
Yeah. I'm just going to
So it takes a knowledge of these types of things.
Yeah. I'm going to be blown away, Heather, if this slight fix, if we go back to just that one foot turned out, fixes all of your back pain. I was
Yeah.
blown away because, well, why don't we get your opinion as to why the knee's hurting? One, because I think I see a lot of clients with knee pain and knee issues in general. So
Yeah.
Heather thinks that the back pain is the result of the knee pain and just like a weird compensation for squatting. But do you think that
She's likely correct.
yeah. So do
Mhm.
you think that the what would the femur be? Would it be retroverted? Is it the right one?
Yeah.
If you wanted
If her foot wants to be turned out,
wants to be turned
then
out.
likely she has a retroverted. We can confirm it right now if you
Yeah.
want.
Do you think that that would be the cause of the knee pain too?
Oh, of course.
Okay.
Wow.
Because the way she's lifting or using her body is not aligning with the actual structure of her body.
Right.
Yeah.
What she's doing is imposing social ideas about
Yes.
how things should
Yes.
look, as
This is
opposed to
very
how
true.
she's actually
Right.
built.
Well, this is why I've been doing for like since powerlifting, I've been doing a lot of unilateral training because it feels better, right? For me to do one leg at a time. It just feels way
Absolutely.
better than bilateral.
Yeah.
So, but
Absolutely.
yeah.
Yeah. This is great. And all this is kind of blowing my mind because like Heather went, she's been going to PT and she's been doing all of the like right things, like trying to activate her glutes and trying to do all this hip compression work that, strengthening the hips and the glutes and etc. And I think it's helped a little bit.
Yeah.
Just
It
because
helps
you're getting
relieve the pain
stronger
and it gets me a little stronger. Yeah.
but you're still getting
But whenever I
injured.
do a bilateral movement,
Yeah.
like a squat,
Yeah.
that's when
Maybe
the pain.
this is the fix.
Well, see, all of these things aren't changing the level of her pelvis.
yeah.
Mhm.
Her right pelvis is still uneven, which
Yeah.
tells me that those changes aren't changing her function.
Yeah. And
Right.
you're now addressing the actual structural problem versus just like getting out of pain, right? I mean,
Well,
you're not
this is
fixing the structure, but you're incorporating it into the strategy to rehab the pain.
yeah. So this is kind of what I talk about in my Solving the Pain Puzzle book, is that
yeah.
chronic pain is a culmination of a functional issue, a structural issue, and a behavioral issue.
Yeah.
And these three things meet to cause chronic pain.
Mm-hmm.
You have to have an understanding a little bit of what's going on structurally in some cases, but you also have to understand how that thing is supposed to be working based on that structure, like femoral retroversion and anteversion. And then you have to understand how your behaviors, how you've been trained to do things, is maybe not in line with both the function and the structure of the thing that you're talking about.
Yeah. That's definitely the biggest discrepancy.
Totally.
Especially nowadays with like social media, and you have all these like physical therapists on there, and they're creating these like reels, and they're like, you have back pain, do this, and this. And it's like, okay, great. But like, that didn't help me. So
And this is why a lot of things out there help some people and not others.
Exactly.
Because of course, everyone's on a spectrum of problems to fix. And so those kinds of simple things help simple problems that maybe aren't that deep.
Yeah.
But the people I see are the people who have been in chronic pain for decades, right? And have been to multitudes of practitioners. But the thing is it doesn't scare me because I know exactly how those people have been treated up till now. They've been treated using this component thinking approach. Oh, let's try this stretch and let's try that stretch. Let's try this strengthening. There's no trying when I work with people. We know whether it's going to work or not. And it's because it all comes out in the evaluation and testing. The testing shows us everything. So if you want to, Heather, we can take a look and see whether you have a retroverted femur or not right now.
Yes, let's do that. I will not.
Unfortunately, to some degree, we're going to have to rely on Katie's observation.
Unfortunately is the key word.
Let's try.
Okay.
I've never measured a pelvis before, and I got put on the spot, and it's too much pressure.
No, I'm just giving you a hard time.
No, I know.
But once, like, if I could show you, it's so incredibly easy to measure a pelvis. That once you know that you're doing it right, you'll have it right for life.
I would like to know that, because now I feel like I could do that with all my clients and just be like,
you certainly can, Katie. And you know what? The best way to do it is by practicing.
Yeah.
And once you do about 5 people, you're going to see that, oh, my hand has to be here on top, right? I can't, if I'm back here, well, now because the pelvis can rotate, then I may not be at the very top of the pelvis, right? So only if you come in from the side and you push into that fleshy waist and then push down, will you find will you find that pelvic height.
All right. Looks like I'm practicing a lot with
Okay.
you.
Yeah.
Sounds good.
Got to figure that out.
And it's easy practice. And then
Yeah.
just above that, well, on this skeleton, it looks like it's maybe several inches, but just usually within a quarter to a half inch, you'll feel the bottommost rib too.
Yeah.
Yeah.
So if you keep your hand here and then just move it up a little bit, you're going to feel the bottommost rib cage.
Okay.
And in most cases where you're measuring this, what you will measure is that, oh, the side that has the high pelvis also has the side with the low rib cage.
Yeah. Yeah.
All right. And that's the side bending problem. And it's due to a compensation pattern. Again, 80, 90% of the cases
Yeah.
from some older problem that hasn't been rehabbed correctly here,
Yeah.
or 10 to 20, it's a compensation pattern for the
Yeah.
other side.
Yeah.
Okay. All right. And then you can try the walking trick.
Okay.
All right.
Yeah.
Yeah.
That's a great party trick.
Yeah.
And for the kind of parties that I go to anyway.
Yeah. I was gonna say, that's like, I feel like that's a your kind of, well, I would love to go to that party too.
I'm a geek.
I would nerd out too.
But anyway, this will, you'll see within like, and literally, I've never had someone's pelvis not level
Okay.
doing that.
Yeah. Yeah.
So and then that'll confirm that this is a gait issue and not a structural issue.
Yeah.
Yeah.
It's a compensatory issue.
Yeah. So do you
Okay.
do you change people's gait? Just really quick.
Oh,
Do you,
all
do you
the
try
time.
to change how they walk?
Oh, of course. Yeah.
Yeah.
No one gets out of my clinic. If anyone came to me with back or any other pain in the lower body system,
Yeah.
it ultimately has everything to do with how they're walking.
Yeah. Okay.
And so no one, I don't care how old or young you are, we teach you how to walk correctly, because that's how pain stays away permanently then.
Yeah.
Mhm.
So how should Heather walk then?
Well, first let's determine
Let's do
whether
the
she
knee.
has anteverted or retroverted.
Okay. Perfect. Let's do that.
So
What do
Heather,
I have
what
to
I'm
do,
gonna,
Rick?
well, okay. So Heather, what I'm gonna ask you to do is lie down on the ground on your stomach.
Okay.
All right. And then Katie, you're gonna be behind her.
Okay.
All right. Now, you don't even have to do anything, Katie. You're just going to look for general shape. So,
Got it.
Heather, look, and Katie, you'll look at my arms and I'll show you what to look at.
Okay.
So, Heather, I want you to bend your knees so your feet are up in the air like this. And you don't have to watch me, Heather. Okay, now your knees are bent at 90 degrees. Keep the knees bent at 90 degrees. But now what you're going to do is let your feet fall to the outside like this. Just like that. Just let them fall naturally to the outside. Don't force them. So is one leg moving more to the outside than the other, Katie? Or are they both the same?
Her left for sure.
Moving more to the outside than the right.
Yeah, definitely.
Okay. And now, Katie, or I'm sorry, Heather, what I'd like you to do is straighten your right leg out so it's back down on the floor. All right. And now, Heather, I want you to let your left foot travel towards the back of the right knee. And Katie, you just get an idea of how far that just moved. All right.
Pretty much all the way to the knee.
Pretty much all the way to the knee. Okay. And is her pelvis coming up significantly when she's doing that, or is it staying kind of relaxed?
It's staying fairly relaxed on this
Okay,
side.
good. Now, Heather, you can straighten your left knee and bend your right knee. And for Katie's sake, let's go ahead and have you allow the foot to fall to the outside again so she can see where that's going to start. Oh, yeah, that's a big difference. That's a big difference.
Big difference.
Okay, and now let's go ahead and let the right foot fall to the back of the left knee, wherever it's going to go. Did that move as far as the left or further or what?
It didn't move as far, and pelvis is definitely coming up off the floor.
So what we're seeing, and Heather, you can go ahead and sit up now. All right. So what we're seeing is, I'm gonna reproduce it. The left leg moved way out here, the right very little.
That's pretty much exactly what it looked like.
Yeah. And then when the left leg fell to the right knee, it fell all the way down here, right? And when the right leg fell to the left knee, it maybe fell to here.
Yeah.
Okay. So what is that telling us? Well, it means that, first of all, Heather, you have a hypermobile left hip. Okay. Because that's excessive motion in both directions.
Okay.
Oh, okay.
All right. If you can move a lot this way and a lot this way, that's excessive motion.
Wow.
You should have one or the other. For instance, if you move a lot this way, most people only have this much going the other way.
Okay.
Yeah.
Or if they have a lot going this way, they have very little going this way.
Got it. Okay.
All right. So usually there's a total degree of motion that most hips have.
Yeah.
And you've got more than that, Heather,
Yeah.
on
Yeah,
your
she
left.
sure does on the
Okay.
left.
Yeah.
It was
Now,
all over the
on the
place. Yeah.
on the right side, she has, and you can imagine if my hands are going out like this is pointing the knee in, right?
Yeah.
Yep.
So that's internal rotation.
Okay.
Yep.
So if her foot's going out very little, that means she doesn't have very much internal rotation in that hip joint.
Yeah.
Right.
And if her hip is going further down like this, now that means she's got a lot of external rotation,
Yeah.
right? Which means she has a retroverted femur,
All right.
Wow.
Figured it out.
right? So unfortunately, she doesn't have much motion in either direction.
She sure
So
doesn't.
compared to that left hip.
Yeah.
Yeah.
So the right hip has very little internal rotation and more external rotation. And this
Yeah.
is how we can look at these things in general terms.
Yeah.
She has more external rotation than she does internal rotation.
Yeah.
So does it make sense then for me to point her foot straight ahead when she's squatting?
No.
No, she doesn't have any internal rotation.
So we
So we wanna-
confirmed it.
Yeah.
Yeah,
Right?
so we want to point that foot out when she's
Yeah.
squatting because
Okay.
that's the motion that she has.
Yeah.
Yeah.
Now the left foot, it's less important because she's got a whole bunch of motion either direction,
Yeah.
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 right? Which may be a good thing or it may be a bad thing.
Right.
Yeah. You know what's
'Cause-
funny? I just thought of this. You can pistol squat really well on your left leg.
Yes.
And she cannot pistol squat at all on the right.
Yeah.
No.
Yeah.
Or
Because
like
So-
lateral step downs,
or-
not very
yeah.
high on the right side.
wow, this is
Right.
crazy. We
So-
fixed it. We figured it out.
Well,
Yeah.
we're figuring it out.
We're
Yeah.
figuring it
Uh,
out. Yeah.
So what that's is telling me is that not only does Heather have a knee issue, but she also has a hip issue on the right side,
Yeah.
Yeah.
right?
Oh yeah.
Because the hip doesn't move as nearly as much as the left hip.
Mm-hmm.
But if you needed to do squats, and that's what you absolutely have to do, Heather, then
Yeah.
I would do the squats with more external rotation in
Okay.
the right foot.
I love
Wow,
that.
this is crazy because I remember seeing that too, and I'm
You
like,
remember
oh, this is weird.
My friends used to call it out.
Yeah.
But I was like, no, oh yeah, you're right.
You're
And then I
right.
started to fix it. I started to try to get, I mean, I turned both feet out, but my right one would always be.
Yeah.
Right. And
I-
so
Yeah.
this is what this is about. This whole thing that I've developed, this whole approach, this is all very logical, right?
Yeah.
Yeah.
It's not based on you guys believing what I'm saying because you can see the truth
Right.
of what
yeah.
I'm saying, right?
Yeah. Yeah.
And unfortunately, a lot of stuff that's out there is requiring you to believe what they're saying.
Yeah.
Mhm.
But what I've done is made sure that I've proven what I'm saying and
Yeah.
that everyone can see it. And so any physical therapist who came to work at my clinic would not be able to work at my clinic unless I trained them
Yeah.
Yeah.
because they were all trained in this component thinking.
Right.
And I didn't want any of my chronic pain patients to be seen by a component thinker.
Yeah.
I want them to be seen by systems thinking. And within 6 to 8 months, all of these physical therapists became master clinicians. They could solve
Yeah.
everything that walked through our door, no matter what.
Wow. Yeah.
And anyone can do this. I mean, I'm teaching you guys to do it over Zoom.
Yeah.
So it's so easy and simple,
Yeah,
right? It's
yeah.
logical. And so when I do exams, this is what these kinds of things are what I'm looking at.
Yeah.
Rather than just measuring, oh, you've got 12 degrees internal rotation and 40 degrees
Yeah.
external rotation.
Yeah.
Well, that doesn't tell me anything,
Right.
right.
right?
Right.
So we've got to be able to think about what we're seeing. And
Right.
that's what all of this is about.
That's
Yeah.
awesome because I've known that I've had a limited amount of internal rotation on the right side, but I've never understood
Like what to do about
what
it.
to do about it when I'm
Yeah.
squatting.
Yeah.
Yeah.
Well, do you want to do anything about it?
Yes.
No.
Oh,
Oh.
No. Why would we try and force internal
Oh,
rotation
yeah. No,
on the
right.
hip joint,
Yeah.
right?
Yeah. So if someone had the introverted, am I saying
Yes.
it right?
Yes.
Would you recommend, let's say she had that on the right, would you recommend the left, say, pointed forward and then the right toes pointed inward then? that
If
were
she
the
had
case?
anteverted on the left, are you saying?
No, on the
Or
right.
on the right.
If it were the
So,
opposite issue.
Yeah. So anteversion is a different kind of phenomenon. And so what I do is I don't like to turn the feet in at all.
Right.
Right.
And I'll tell you why in just a second.
Yeah.
But if you have an anteverted femur, I have people point their feet forward.
Okay.
Okay.
All right. So what's going on with femoral anteversion is because the thigh bone is internal. And Katie, you're absolutely right to think that. But over many years of experimenting with that idea, I've learned that's not the way to treat it.
I just feel like, doing that excessively, then I feel like the knees really wouldn't track with the toes, which would cause some, just wouldn't really help the issue there. So,
so the anteverted femur is automatically built for more internal rotation.
Okay.
And we know that internal rotation increases compression in the hip, knee, and foot.
Yeah.
So pointing the toe in would bias it automatically into internal rotation, right? So if you have an anteverted femur, you need to have stronger external rotators to decelerate the tendency of your body to internally rotate.
Okay.
What are the primary internal rotation decelerators of the hip joint? The gluteus maximus.
Okay. Yeah.
All right. That is a primary external rotator. So for those people, you want to have extra strong gluteus maximus muscles.
Gotcha.
To control that internal rotation. Now, because the gluteus maximus is an external rotator.
Yeah.
Simply by having the foot in a neutral position rather than an internally rotated position,
right,
means that this now is in relative external rotation for that thigh bone.
Right. Okay.
Which means that it will bias the gluteus maximus to turn on automatically in this.
Perfect.
Better than if the foot was pointed in.
That makes total sense. Yep.
Okay.
Yeah, for sure. So, okay, I know we're running out of time, which is sad because I have like 20,000 more questions. So I really feel like we should bring you back on for a part 2 because I almost want to get into like each joint and what you would recommend. But so like the systems approach that you're talking about versus the like component, you have this method that you created. Is that basically the fixing you method? I just want to make sure we touch on that before we go so you can explain that really quickly.
If you go to my website, rickolderman.com, I've created a practitioner's course, online course to teach people this stuff. And I feel that anyone from coaches to surgeons needs to know this information.
Yeah, definitely.
If you're dealing with pain and you're dealing with movement of the human body, then you need to understand these concepts because they're fundamental to getting people out of pain or keeping them out of pain. Right. And then I've created a digital home program so people can solve their pain at home.
Wow.
Using these types of ideas.
Cool. That's so awesome.
Yeah.
That's really cool. Wait, we didn't address the gait issue really quickly for Heather's case study.
Yeah.
So now that we've found out that she has an retroverted femur, what do you recommend as far as the walking and the gait pattern?
Well, we're going to, for sure, Heather, turn your foot out between 3 to 5 degrees.
Interesting.
Whenever you're standing and walking.
That's awesome.
This is crazy because, well, for me personally, I've always walked with my toes pointed forward, and I feel like people, I mean, it's kind of, what do you look like? Kind of like a duck. It's not like super, turned out, but like they're slightly pointed forward. My brother and I both do that. So I wonder if I have the same thing. I have no idea.
Well, now you will have an idea. Heather can measure you. Right?
I think I need to measure it.
We're going to do some practice.
So Heather's going to walk with just the right foot turned slightly outward.
Interesting.
Well, you might as well turn both out because the left hip has excessive motion.
It's able
Therefore,
to.
it has more available internal rotation.
Wow.
And we want to bias that glute to turn on better. Because of that.
Yes.
So we want to. So, and Katie, you just brought up a great question.
Yeah.
Why would someone with retroverted femurs not point their feet outward?
Right.
When that's the way the shape of their femur is.
Yeah.
The reason is because we're socialized to walk with our feet pointed forward.
Yes.
And you said it absolutely. You said, oh, well, I don't want to walk like a duck.
Right.
And so that's a judgment about what it looks like to walk with your feet outward. And this is the primary thing that most people say. Oh, you want me to walk like a duck?
Yeah.
Well, that's a judgment.
Yeah.
Yes is the answer.
Yeah.
Because you're going to feel a lot better when you do.
Exactly. Wow. Or it's like, it was more of like, well, we want to get you to not walk like a duck. We want to get you to walk with your, your toes pointed forward.
Because it's incorrect to look like a duck.
And I was trying to like do it, and it literally, when I walk like that, I feel like I just feel like really awkward. Like I'm walking like this almost but I know it, when you look at me, it doesn't look like that, but that's how I feel. It just feels so awkward and weird, but
and in my 25 years plus of treating pain, I have never treated a duck with back pain, hip pain, knee pain, or foot pain.
Yeah. I love this.
Totally,
Okay. If you're down, I really would love to get you back on because I want to talk about the upper body, you know, the common joint issues that we see. I really want to get into the knee pain too. I have like 20,000 questions on that. So yeah, I don't know if you're cool. We should definitely set that up because I know you have a hard out soon. So yeah, I guess I'm not going to ask you any more questions because it's going to lead to more.
Yeah,
so
it's time.
let's just, why don't you tell everyone where they can find you and learn more about you?
Yeah. So if you just go to rickolderman.com, you can find all my books. I've written 7 books now.
Wow.
And
awesome.
you can find all of them there. There are links to Amazon. You can find my digital home programs. I've got a free ebook there for you if you want.
Awesome.
My practitioner's course. My recent book is Solving the Pain Puzzle. And it talks about all of these concepts that we're talking about today, but in more of a non-medical, because a lot of people get confused when you talk about muscles and joints and so forth. So these are case studies of how I solved cases that other people couldn't solve using these ideas. And it may be a gentler way of introducing yourself to these kinds of concepts of systems thinking.
Yeah.
So
cool. Well, and we'll write all this in the show notes for the episode. We'll link your website, social media. If you have it, you can send it over to us. We'll link all that in the show notes. So yeah. Well, this was really great. I feel like this kind of blew my mind. I feel like we've been saying that a lot with a lot of the guests we have lately, but I thought it was just going to be like, you know, general physical therapy. Like, we got to do X movements and find the root cause of the issue. Then you progress it with training, et cetera, et cetera. But this was just completely opposite. And it's really cool. I feel like we might have potentially helped to solve your back pain.
Yeah. I'm going to work on it.
Well, there's more to it than that. And we can go over that next time.
This is the first next time. Yeah.
Heather, you're a mess.
Basically, I know. We're going to do Heather's physical therapy on the podcast. Right. So we probably will have you on many more times, Rick. So,
okay.
Yeah.
All right. Awesome.
So
I'll
I guess
send
everyone,
you
exactly. Stay tuned for part 2 because we definitely I want to continue the conversation because I have a lot more questions. So,
all right, great.
Yeah.
It'll be fun.
Well, thank you so much, Rick. This was really awesome. It's really cool to hear about your method. So we'll see you on for part 2.
Sounds great.
All right. Take care.